Hi everybody, my name is Benedetta Conte. I am a medical oncologist working in Italy at the Maggiore Hospital in Novara. I have been attending the San Antonio Breast Cancer Symposium, and today I'm commenting on the main data presented on metastatic hormone receptor positive HER2 negative breast cancer. Yesterday in the general session, the main results of the SABCS'25 trial have been presented, comparing sacituzumab govitecan versus the physician's chemotherapy choice in patients with luminal metastatic disease as a first-line option after all endocrine-based treatment have been exhausted in this patient population. The trial failed to meet its primary endpoint, which was progression-free survival for independent central review. However, a trend for a benefit in overall survival and a positive progression-free survival favoring the sacituzumab govitecan arm was observed when the progression-free survival was assessed by investigator-assessed endpoint. So probably the negative results are due to the discrepancy from the central review and the investigator-assessed review for progression-free survival. However, since the trial is negative for its primary endpoint, probably sacituzumab govitecan will remain a valuable choice for later lines of treatments in the disease subtype. And then the rapid-fire session on metastatic luminal breast cancer just finished few minutes ago. And we also have really interesting data from this session. We have new data regarding the use of SERDs in metastatic luminal breast cancer, in particular the ELEVATE trial, which evaluated the combination of elacestrant, an already approved SERD, with everolimus, abemaciclib, and other targeted treatments, showed a really promising median progression-free survival results from the combination of elacestrant and abemaciclib or everolimus, 14 and 8.3 months respectively, confirming that combining a SERD with a targeted treatment probably will be the most efficacious option following progression to CDK4/6 inhibitors. Moreover, we had new updated data from the SERENA-6 trial showing that patients enrolled and allocated to the camizestrant plus CDK4/6 inhibitors arms, so the one shifting to the SERD plus CDK4/6 inhibitor, once the mutation in SR1 in the ctDNA has been detected, have a longer time to chemotherapy or ADC initiation, meaning that probably the early switch before radiological progression in patients with a rising SR1 mutation in the ctDNA could really derive benefit, clinical benefit from this combination, although some questions still remain open because this trial did not include crossover in the control arm, so we can't really answer the question whether this patient will really benefit from this early switch. Moreover, we had also interesting data from another trial evaluating the endocrine therapy plus abemaciclib versus chemotherapy as a first-line treatment in patients with high-burden visceral disease. And this trial basically confirms what we already saw in other trials, confirming that actually combining the CDK4/6 inhibitors with endocrine treatment is the right choice even when we have a high visceral disease burden. And we also have really interesting data on the PALLAS trial, which assessed the survival outcomes and the treatment choices in patients who relapsed at a distant recurrence following adjuvant treatment with endocrine therapy or endocrine therapy plus adjuvant palbociclib. And what we see from this data is that probably patients recurring after an adjuvant CDK4/6 inhibitor have a more aggressive disease with a different biology. And so probably this is the type of the population we are going to treat in the future following adjuvant abemaciclib and adjuvant ribociclib, even though these data are really only hypothesis generating and preliminary. And then we also have new data from the Capitello trial showing that there is about 20% of patients with alteration in PTEN, AKT, or PI3K pathway detected only in the tissue or in the ctDNA, meaning that probably expanding the test to both ctDNA and the tumor tissue could expand the population eligible for this type of treatment. I think that's all, and I thank you all for the attention.